figure out how to turn that off. Okay, well, good morning. Thank you for joining us for the PGY2 Pain and Palliative Care webinar series. We are super honored this morning to have presenting to us on risk mitigation and palliative care, Dr. James Ray. Dr. Ray is the James A. Otterbeck named Associate Professor in Palliative Care and Hospice at the University of Iowa College of Pharmacy, and this is really a significant treat to have him share his expertise with us this morning. So with that, I will turn it over to Dr. Ray, and thank you for joining us.
Thank you, Dr. Herndon. Good morning, everyone. I don't know about a treat, but I hope that at least begin to spark some communication, some dialogue as it relates to risk management and palliative care. So these are just the three objectives that I wanted to discuss today, and that was to identify the need for risk management in opioid prescribing and palliative medicine. And I think that that's an area that still is somewhat controversial and needs a lot more clarification. To review the current literature that we have available to us as it relates to opioid misuse and abuse in the palliative medicine field, with a particular focus on cancer patients, and to lay out a number of steps that we might think about as it relates to integrating risk management into the daily practice of safe opioid prescribing. I thought we'd start out with the case. Maria is a 45-year-old woman who was recently diagnosed, unfortunately, with stage 4 non-small cell lung cancer. And the medical oncologist referred Maria to your pharmacotherapy clinic for assistance with opioid risk assessment and future co-management of her cancer pain. Maria is a single mother of 3 children, one a teenager living in a rental trailer at the local trailer park. Maria works at Lowe's as a cashier, but has been unable to work for the past week due to worsening pain. Her only other past medical history was seizures, idiopathic seizures as a child, and she's not had any seizures since college, and she discontinued her anti-seizure medicines approximately 10 years ago. This is her current medication list: hydromorphone, 8 milligrams every 4 hours around the clock by mouth. She takes an additional 4 milligrams every 3 hours as needed for breakthrough pain, averaging somewhere between 4 to 5 doses per day. And she's also on citalopram, 20 milligrams once a day. Her only allergy is to penicillin. She's had previous intolerances to both MS-Contin and gabapentin. She had persistent nausea despite regularly scheduled anti-nausea and vomiting medicines with MS-Contin. And she never developed any type of CNS tolerance to gabapentin. Other symptoms: last bowel movement was 3 days ago. She has anxiety, depression, and insomnia that was scored relatively high on her ESAS assessment. Other relevant history is that she does drink 1 to 2 glasses of wine or cans of beer 3 to 4 times per week. She continues to smoke 1 pack of cigarettes per day and has done that for the past 20 years. She had used marijuana recreationally while she was in college, but had stopped using that prior to the birth of her first child, and she does not offer up any history as it relates to illicit drug use. So for me to take an opportunity to take a drink of coffee, I would ask you what concerns you have in the ongoing management of this patient. You can either chime in or use the chat. So I'm not sure that I'm seeing the chat. Ah, there they are. So Joe, you're saying her ethanol use, and Scott, you're asking cardiac disease. Who else lives in the trailer, right? Yeah. Anyone else want to offer up? History of marijuana smoking, right? So this issue about, do we worry about remote history as it relates to our current use of opioids at this point, or is it just something we tuck away in the back of our mind? All right, so those are good points, and I think we'll come back to those as we move through the talk. So I think that this is always an issue that I certainly talk with student pharmacists about, is who is the abuser. And like the old saying goes, you can't judge a book by its cover. There really is no pathognomonic picture that you get of someone who's an abuser. It doesn't matter the number of the design or the amount of body art or the number of piercings or their location. That gives us an indication as to who may or may not abuse opioids. And I would actually contend that the person up in the top of the slide may be the person at highest risk, just because of ongoing and persistent access to opioids easily. I don't know if any of you have had the opportunity to read any of the executive summary of the Surgeon General's recent report that was released yesterday. I thought some of these statistics were quite significant and actually were far greater than what I had realized. But over 175 million people aged 12 and older, which is, and that's 65.7% of this population reported alcohol use in the past year. Over 66 million, or 25%, reporting binge drinking, and alcohol does remain the number one issue with regards to misuse and abuse of any substance in our society. And of all substances that are misused and abused, it does kill more people than any other substance. 36 million people report using marijuana in the past year. 12.5 million reported misusing prescription pain relievers, so using them for a non-medical purpose. And over 300,000 new people reporting using heroin in the past year. Almost 8% of the population met the DSM-5 criteria for substance use disorder for alcohol or illicit drugs, and another 1% met diagnostic criteria for both an alcohol and illicit drug use disorder. So this is our future. This is what we will be facing. And I think the important provision that I always try to put forth is that these people are going to get sick. They're going to develop serious illnesses. And this is going to always be a companion with them until the time that they die. And we need to realize that this is very much an issue that we need to be concerned with as it relates to potential implications of risk management in the palliative care setting. The other important thing, as you all know, is that despite there being a fairly large number of individuals that meet the criteria for substance use disorder, only a small percentage of those people actually receive any type of treatment. And of those that do receive treatment, it's mostly in specialty substance use disorder. So we still have a wide disparity of patients that have significant unmet needs as it relates to the suffering of the disease of addiction. Those people are going to be patients that we're going to continue to be dealing with over the next several decades. And I'm sure, as all of you are aware, that this year, there'll be greater than 17,000 deaths from opioid overdose in the United States. That's where we can say single-use opioid, not multi-substance use. That now surpasses multiple motor vehicle accidents as being the leading cause of accidental death in almost every state in the union. And this really is a problem of mostly white middle-aged Americans. It is clearly a disease of Caucasians with the misuse and abuse that is occurring with opioids. A recent review of screening questionnaires and urine drug testing from 5 national cancer centers in the United States determined that 1 in 5 patients may be at risk for an opioid use disorder. I think that this is much greater than most medical oncologists ever presume being an issue. This has not really hit their radar the way that it should have. My former colleagues at the University of Virginia, our first palliative medicine fellow, Paul Tan, did this survey of 94 accredited palliative medicine fellowships just this past 2 years. And they looked at what was going on in accredited palliative medicine fellowships as it related to screening and policies associated with misuse and abuse and issues associated with opioid use in their population. And what they found is that only about 40% of them had any kind of policy for screening a patient, and less than 20% screening potential family member that could be a caregiver for that patient. Only about 1/5 of them had any kind of policy dealing with diversion in their clinic. Only 1/3 used some type of screening tool, and routine use of urine drug testing was extremely rare in these fellowship programs. And in this survey had a response rate of about 45% responders to the survey. So a pretty decent sample of the ongoing fellowships that are out there in the United States. So I'm sure that you're all fairly familiar now with the CDC's guidelines on the use of opioids for chronic pain. This is sort of a distillation of those guidelines that the Surgeon General has put forth on his site, turnthetiderx.org. And as you probably are all aware, the CDC sort of gave patients in palliative care and end of life a bye as it relates to issues associated with what we would otherwise think we should be doing in patients with chronic opioid therapy. And based upon the statistics and the demographics I just showed you, I think that that was a grave mistake. I think that our patients that are in palliative medicine have just as great a risk, if not greater risk, to go back to their chemical coping or to have recidivism of their addiction. I can't think of anything that's more stressful than being told that you have a life-threatening or life-limiting illness that would make you want to return to using substances in ways that you shouldn't. So risk management in pain management has followed this universal policy, universal precautions that was first put forth by Gourlay and Haidt back in the late 90s. Del Fabro from MCV has taken that and has modified it as it relates specifically to cancer pain management. And it starts out by talking about, well, what's the differential diagnosis and understanding what are the tumor-related causes of the pain and what are the patient-related factors influencing pain and the expression of that pain. That really means that we need to do a really thorough history, not just physical history, but and we need to do a very in-depth psychological history in our patients with cancer pain or in other palliative settings. We certainly do need to understand the risk factors for chemical coping, whether that be ongoing tobacco use, other psychological illnesses, whether there's a history of pre-adolescent sexual abuse, both in men and women, which is a high predictive factor for people that will go on to misuse and abuse and addiction of prescription and illicit drugs. Some type of screening instrument would be preferable to use at the first visit. There is no gold standard. We'll talk a little bit more about what we know about using these screening tools, at least in the cancer population and palliative care population. Informed consent, which includes not only the concerns about addiction, but many of the opioid adverse effects that we now know are non-analgesic, such as gonadism, the potential for opioid-induced hyperalgesia, potential for immunosuppression, and that we continue to ongoingly de-emphasize that opioids are the only sole treatment for pain. Informed consent, I think, is one of the things that gets forgotten about in this process, that a lot of times it's seen as sort of a one and done sort of phenomena when we trot out the opioid agreement. But this really is an opportunity to revisit this each and every visit to make sure patients understand, because most cancer patients in most visits, they get maybe about a tenth of what's told to them in each visit. And so they really do need to have this information revisited and emphasized each time they're seen in the clinic, whether that's in the palliative medicine clinic or in the medical oncology clinic. Just like with chronic non-cancer pain, we certainly do want to do a pre and post assessment of the pain level and use the 5 A's to routinely reassess where we're going. We'll talk about that a little bit more. We do need to revisit the differential diagnosis. And I think that as we have this increasing population of cancer survivors in this country, now over 2 million plus, that in patients with no evidence of disease, those patients probably need different treatment goals than those patients that have advancing progressive advanced cancer. Documentation is essential, just like it is in chronic non-malignant pain. And then there becomes the ethical concerns of what do we do with discharging a patient from our care who has advanced cancer, has a legitimate medical need, but however has ongoing substance misuse and or active addiction. Do we discharge them from our practice? Do we continue to take care of them in our practice but not prescribe opioids for them? Or do we seek out substance abuse specialists that can help us co-manage these patients from the beginning? Earlier this summer, the American Society of Clinical Oncology published guidelines for the use or for the treatment of ongoing pain in cancer survivors, specifically in patients that have no evidence of active disease. And so I'm just going to briefly review some of what was published in those guidelines. Again, pretty much standard from what we would think about in chronic opioid therapy for chronic non-malignant pain. No surprises there. Again, making sure that we're doing a really thorough personal and family history about substance abuse, both ethanol, prescription, and illicit drugs, and having a clear understanding of what the major psychiatric disorders are in the patient, as well as in the family members that may be active caregivers for the patient. So the screening questionnaires that have been utilized in chronic opioid therapy for patients with chronic non-malignant pain have not been as extensively studied in the cancer pain population or in the palliative medicine population. There are a couple validated studies using the opioid risk tool. And for those of you that access these slides again, where you see the underline, these are hyperlinks to these tools if you need to reach out for those later on. But as many of you probably know, the opioid risk tool is a screening tool that can be used quickly, has probably not the greatest reliability, but it is something that can be done fairly quickly. And I think its overall reliability certainly increases when it's part of an overall clinician interview as opposed to just a pen and pencil screening tool that's done by the patient. The SOAP-R tool, which is a 14-item tool and is self-performed, is a bit more opaque in its questionnaires. It's not quite so obvious, and I think is probably a more useful tool, although it's more in-depth and takes more time, and it would be best used out in the waiting room prior to actually seeing the provider. and a report then being generated prior to the provider seeing the patient in the clinic setting. The Dyer tool, while some people have used that as a pre-screening tool, it's really was designed principally to be used in follow-up to look for aberrant drug-taking behavior. So I don't think that it's really as useful a tool to be used as a screening tool. But in one study that looked at the comparisons of sensitivity for the ability to pick up potential risk for opioid misuse and abuse, a trained psychologist understanding the ins and outs of clinical interview was by far and away the most sensitive, followed by the SOAP tool. You can see the ORT and the Dyer were much less useful in the overall ability to screen. And when you combine the clinical interview with the SOAP-R, the sensitivity went up substantially. So I hear someone typing in the background. Can you please mute the microphone, please? Thank you. Yeah, another tool that's been designed that I think has a lot more promise, at least in the palliative medicine setting, is the SOAP short form. And this is the questionnaires. And anybody that scores a 4 or above on the SOAP SF would be considered, that would be considered a positive screening for someone who has risk for misuse and abuse. So a couple centers that have used the SOAP SF as part of an overall assessment. At MD Anderson, again, a score of 4 or greater was considered positive and considered high risk for opioid misuse. 29% of 522 pain clinic patients were found to be positive on the SOAP SF. And these patients were generally younger patients. They endorsed more pain. They required a higher morphine equivalent daily dose, and they had more symptom burdens, specifically of depression and anxiety. A study done by the group in Pittsburgh at UPMC, they found that 46% of 57 new patients that they utilized the SOAP SF and had a positive score. So again, a score that would indicate high risk for misuse and abuse. Now, in this particular study, less than 5% of the visits included a urine drug screen, but in that 5%, 56% of those people had an aberrant result on their urine drug screen. So I think that we're only beginning to understand the overall potential problems that we have. At UPMC, 91% of these people had cancer diagnosis. The palliative medicine clinic is actually across the street from the UPMC Cancer Center. But a third of those patients had no evidence of current disease. So this is the increasing amount of patients that we're going to have challenges with as we move forward, is what do we do with these patients who have no active cancer but have ongoing sequelae associated with their cancer that still produces a legitimate need for pain medicine, but it's not due to their cancer. It's due to their treatment, it's due to cancer-induced neuropathic pain or other causes. And in fact, a survey done at the Fox Chase Cancer Center just recently reported is that in 40% of their outpatient clinic, they're cancer survivors, again, with no active disease. Another questionnaire that I think can be a useful screening methodology is the CAGE questionnaire. And while it's not specific for opioid misuse and abuse, it certainly does give us an indication of chemical coping. And when you look at the range of studies where the prevalence of the CAGE score is positive, the the incidence is anywhere from the prevalence is anywhere from 4 to 64%. So in older studies done by Bowera when he was in the Edmonton Palliative Care Center back in the late 80s and early 90s, that they showed in the outpatient setting 24 to 33% of their patients had a positive CAGE, and in the palliative care unit, nearly a third of their patients. And then he repeated this work after he left Edmonton and went to MD Anderson. They recently showed that in solid tumor patients, about 17% had a positive CAGE, and as you might expect, head and neck cancer, it's very prominent to have a positive CAGE score. And again, what they've found is that is linked to patients with a history of illicit drug use. Sorry, I missed the U there on use. Tobacco use, greater symptom expression, again, higher morphine equivalent daily use, and it also translates into unsafe use of opioids. So we really can, by using the opioid risk tool or other screening tools, we can begin to stratify patients into buckets that we might think about as we would want to tailor their ongoing follow-up and how closely we may want to see these patients on an ongoing basis. So I really just want to focus on what we would consider high risk or very high risk patients. And again, the ASCO guidelines really kind of point out, well, we need to make a decision about whether we're going to prescribe opioids or we're not going to prescribe opioids. Where risk of abuse, based on our screening methodology and our history taking and looking at their PMP results and other access to information tells us that they're at low risk, then obviously we would move on to prescribe. But if they're in the moderate or high risk, then I think we need to ask ourselves some other questions. And one is the severe pain compromising their physical or mental well-being? Is it having such an important impact on their activities of daily living, their ability to get to their treatment, the potential for making their depression or anxiety worse? Then the risk versus benefit probably is outweighed by using the opioid. But we certainly want to look, whenever possible, are there other alternatives that may help with the pain and provide manageable risk other than just using opioids? And is the risk of drug abuse the more severe risk, where we're worried about relapse into heroin abuse or other significant opioid abuse, or less serious where patients appear to be back into kind of a chemical coping mode? I like to think about this issue of working with high-risk patients in this stratification as sort of getting the short leash out, where we have very close ongoing observation of what's going on. So we want to look at what's been going on with the recent history. We want to continuously look for episodes of ethanol abuse or drug abuse, certainly in looking for indicators of the patient's been in a motor vehicle accident, have they had a have they had a DUI, have they had some run-in with the law that would be an indicator that things are kind of getting off the rails. Do they have a history of addiction where they have limited or no system to sustain their recovery? And for many of the patients that we have within our palliative medicine clinic, especially our head and neck cancer patients, that is a huge concern. They have limited resources, they have fractionated families, they continue to chemically cope, and so it's difficult to know if they're going to be able to sustain their ongoing recovery. If there's a strong family history of ethanol or drug abuse, particularly if those individuals live with the patient, then we need much greater control. And any time where there's a history of a major psychiatric disorder, particularly one that has not been well managed, these patients need much closer follow-up. So that leash entails detailed interviewing about ongoing drug-related behavior, and that may utilize other validated tools such as the CALM. Certainly asking family members that work with the patient, that live with the patient, know their behavior, understand what's going on with them at home, look at how they're utilizing their drugs. A check of the PMP each and every time we see the patient before opioids are ordered. Urine drug testing, I think that this remains a controversial issue in palliative medicine. I can tell you that at my former colleagues at the University of Virginia, this was a well-integrated part of their overall risk management plan in the palliative medicine clinic, and they used urine drug testing routinely. We're still working on integrating that into a standardized fashion here at the University of Iowa. And certainly pill and patch counts can be another useful check in the overall adherence monitoring process. And then what do we do about aberrant behaviors? It certainly does bring up the whole reconsideration if we're going to go on with opioid therapy. And can non-opioids do the job for us? And oftentimes in patients with metastatic cancer, non-opioids are not going to do the entire job. So then we need to think about that these patients would have limited access. Certainly if we were using something less than a C2, no refills or limited refills. And I think that the essence of this really tight monitoring is very small, frequent prescriptions. And we've gone to the point where in certain patients that they are not allowed to use any more than one opioid. So they have no short-acting drug for breakthrough pain. They are only prescribed a long-acting drug for daily use. And in this situation, most oftentimes we will go to dispensing one transdermal fentanyl patch every 3 days, where they come in, they get their patch put on, they leave, they come back to the clinic, that patch needs to be intact. We take the patch off, we dispose of it in the clinic, we put a new patch on. So very tight control where they have limited to almost no access to the opioid. And if it's clear through their urine drug screening, PMP results that there is clear misuse and abuse and or addiction, then there needs to be a mandated consult with an addiction specialist and or a psychiatrist or psychologist or a substance use counselor that is going to be integrated and be part of the ongoing co-management of the patient. If the patient will not be adherent to that request, then there's discussion about the fact that we can no longer manage their opioids. We'll be happy to continue to take care of them, but we can no longer write their opioids for them. So, as you all know, ongoing assessment certainly goes beyond just the simple pain severity ranking. We want to use a validated tool such as the current opioid misuse measure tool. And I think the pain assessment and documentation tool is another good tool to give us an indication of not only how is their pain being managed, but what are they doing from a functional standpoint? How are they handling adverse events? Is there presence of aberrant drug-taking behavior that we need to try and nip in the bud as quickly as possible? And an ongoing opportunity to, again, review what the rules of the road will be as far as continuing to manage opioids for these patients. So I do think that the 5 A's are extremely important for us to assess each and every time. The PAD tool uses the top 4. I think we need to make sure that we integrate affect as the 5th A. And again, remembering that chronic opioid therapy can itself induce depression, and that after greater than 90 days, the hazard ratio is anywhere from 1.3 to 2.05. So it's not an insignificant finding. And obviously the other issues that we need to be concerned about are chronic opioid therapy produces endocrinopathies that can masquerade as depression, but we need to be assessing for these other non-analgesic effects, not only hypogonadism, but the potential for hypothyroidism and cortical insufficiency. So, like I said, adverse events, I think, is something that our clinical medical oncology colleagues sometimes forget about. Had a patient admitted to the hospital yesterday that we had been following in the clinic, but had been seen most recently in the medical oncology clinic. Turns out that she came in with symptoms of what looks like malignant bowel obstruction, hasn't had a bowel movement for the past 10 days. So even the simple things of making sure that our patients don't have problems with constipation continues to be a poorly managed issue, which should be something that should be standard for patients, especially with cancer pain that are getting long-term opioids. Neurotoxicity has a very wide range of problems, and I think that sometimes these issues, these more milder cognitive issues of changes in mood, memory problems, sometimes doesn't always get contributed to opioids the way they should be. It requires more careful assessment. And another point that most clinicians are still not aware of is that the use of chronic opioids can actually induce central sleep disordered breathing. So central sleep apnea is certainly a risk factor with chronic opioids. It appears that after 6 months of exposure of greater than 100 milligrams of morphine equivalents per day or more, that there's a significant increase in central sleep apnea, particularly when used with concurrent benzodiazepines. This is an issue that we have spent a lot of time trying to sensitize, particularly our medical oncology colleagues, not to be giving out standing doses of benzodiazepines when patients are first seen in the medical oncology clinic. The PMP is a workhorse that, just like in chronic non-malignant pain, anyone in a palliative medicine clinic that is using chronic opioid therapy should be using the PMP. The basic concept should be that it should be reviewed by the prescriber prior to each new prescription being filled, and should be reviewed by the pharmacist prior to filling each new prescription. I know that a lot of our providers feel that this is onerous and it's difficult, and depending on how well your PMP works and whether they're moving to integration of the PMP into the EMRs, there's going to be obviously pushback, but we really have been focusing on getting our providers to do this each and every time the patient is seen. And now that Dr. Lockman is here at the University of Iowa and working in the outpatient clinic, even if the providers aren't doing it, we have a pharmacist that's reviewing the PMP on every patient that is being seen in the palliative medicine clinic prior to a new prescription of an opioid being written. I think that this is really critical too, about when we're having patients referred to us, because we have unearthed a lot of discrepancies from patients that have come to us from our medical oncology colleagues, where we find out that the patient is seeing several different providers, going to multiple pharmacies, where there's been clear misuse and abuse going on. It's been flying under the radar in the oncology clinic for sometimes up to a year. Drug testing, for us, the urine drug test is the one that we continue to use, and I think that there could be conversation about what's the best way to do this. Do you use a point of care where you're looking for either the presence or the absence of the drug and then sending it on for confirmation? That's what my colleagues at the University of Virginia used to do. They would do a simple test to make sure the drug was there. If it wasn't there, then they sent it off for confirmation so that we wouldn't falsely accuse patients of not taking their drug or diverting their drug. Here at the University of Iowa, we just send them all out for quantification rather than doing that first step. So again, I think it's imperative that whether you're starting opioid therapy in the palliative medicine clinic or you're inheriting this patient from another provider, patients need to have a baseline urine drug test. I don't care whether they're 85 years old and they're the friendly grandmother type and you would be the last person you would think that would have a problem, or they're the 25-year-old with multiple piercings and tattoos. These people all need to have urine drug tests as a universal precaution. And then the frequency is really determined by the risk categorization, just like it is in chronic opioid therapy. So low risk, once every 6 months or maybe once a year. Medium, maybe quarterly. In our high-risk patients, I vote for those patients to be tested every time. Now, there are people that say that they still should be using random testing because in those high-risk categories, those patients know how to thwart the tests. They'll adulterate the tests. They'll do other things to try and circumvent being tested positive. I think that there's still a lot of value in continuing to test patients every time if there's a high-risk situation. So Michelle's question is, are patients responsible for the financial side to confirm urine drug testing? If uninsured, does the hospital pick that up? So yes, patients are responsible for the financial side. If we have patients who are uninsured, that is waived or defrayed by the hospital in some way. I don't know the exact details of that, but yes, the patients are, for the most part, financially responsible for the urine drug testing. And Scott's question, I'm sorry I missed this before, do these data separate one-time misusers from more frequent or habitual misuse? I'm not sure I completely understand your question, Scott, but maybe we can circle back on that in a minute. For those of you that are still maybe not completely familiar with urine drug testing, these hyperlinked sources I would highly recommend to you. The bottom one is a monograph that gives you lots of great detail on the ins and outs of urine drug testing. I would tell you that there's a tremendous amount of nuance associated with urine drug testing. I would highly recommend that you understand thresholds of these tests and that you have a toxicologist that you can have almost on speed dial to talk to as it relates to when you have results that can sometimes be on the borderline of false positive or false negative. So my former colleagues at the University of Virginia had begun to look at this back actually in 2012. And that started by doing a retrospective chart review of 114 cancer patients that they had seen just in the month of September. The palliative medicine clinic at UVA is actually embedded within the cancer center. And patients, at that time, they were using and continue to use the opioid risk tool as their screening tool as part of an integrated interview with the patient. And so you can see that at the time, the overall amount of obtaining urine drug screens were low. But what they found is that in the urine drug screens that they did get, particularly in the patients with moderate, who came through as either moderate risk or high risk on the ORT, there was a fairly substantial amount of those being abnormal. Now at that time, the majority of these tests were abnormal for marijuana, but not all of these patients were just marijuana, and we had a fair number of patients who also tested positive for cocaine. And so this became part of what then led to developing a policy at UVA where all patients would get screening urine drug screens both at the beginning of being seen in the clinic and then in follow-up. So a couple other studies that have looked at urine drug screens, at least in the cancer patient population. A very interesting one actually from the National Cancer Center Institute in Bethesda was a study that was conducted over 18 months. And the reason to get a urine drug screen was based solely on the clinician's judgment about there might be aspects of a substance use disorder taking place in their patient. So what they found in that setting is that 73% of these people had abnormal urine drug screens, either inappropriately negative or positive for unprescribed substances. And only 1 in 5 actually had cannabis as the sole substance of misuse. The most tested positive for unprescribed opioid or illicit drugs. And while this is not a frequent thing that they do at MD Anderson, again, in the few patients that they did do urine drug screening, a large percentage of those patients had abnormal tests, and most of them were for illicit substances. So I would submit that we are really just beginning to see the tip of the iceberg, at least in cancer patients in palliative medicine clinics. And I would presume this to be in other disease entities that we may also see in palliative medicine clinics. And again, just to refresh your memory, urine drug testing, because of the differences in metabolism, you certainly need to be very clear about metabolic fate when you're doing interpretation of urine drug screening. This would be a great topic just to have for another talk for us sometime in the future. So I'm just going to try and quickly wrap up here. I think opioid treatment agreements, a lot of people sometimes think that they're about as useful as the paper they're written on, and unfortunately most of the time they're very one-sided. It's all telling what the prescriber expects of the patient, not necessarily what the patient should expect from the prescriber. I think that many times there's not enough thought given to the reading level and the medical ease. We've simplified ours here so that it's just a one-page document, that it's at a sixth grade reading level, and it's really designed to be taken out each and every time that we meet with patients if we think that something bad may be happening as it relates to their opioid use, to refresh their memory about the kinds of things that we want them to do in using their opioids appropriately. So again, on that ongoing assessment, we can use these tools such as the COM and the PADT, combined with the PMP review, pill count, urine drug testing, and discussion with the family about functional status at home. And remembering that pain patients, even patients with advancing illness, can fit into the spectrum of chemical copers all the way up to patients with active substance use disorders. I'm going to just suggest that you all probably are very well aware of what behaviors look like aberrant activity. And again, we tend to see some of this happening, especially in cancer patients who have not had their pain well controlled. And so while it may initially be indicative, I think it requires further investigation and further discussions with the patient in just an open, objective, non-accusatory way of why are they doing what they're doing with their opioids. However, when we begin to see these kinds of problems that we often relate to significant misuse and abuse and or the potential for going down the rabbit hole of addiction, these are times where we really need to step in and either shorten the leash very short or talk about the need for the patient to be seen by another provider. So to go back to the case, Maria, at least on the opioid risk tool, would have moderate to high risk stratification. Her urine drug test that we did at the initial visit came back with marijuana and benzodiazepines. Remember, benzodiazepines were not in her drug profile. She had not told us that she was taking benzodiazepines. And in fact, when we go to the PMP results, she had 2 other prescribers prescribing for her, and she'd been to 3 other pharmacies. And again, remembering she has a teenager at home. So what do you want to do now? All right, so everybody must have fallen asleep with my monotone voice. So I'm gonna press on. I'm gonna say that one of the things that we need to be thinking about is that our harm reduction needs to also include the co-prescribing of naloxone, just like we've begun to be doing in our patients with chronic opioid therapy for chronic non-malignant pain. We need to be thinking about these risk categories in our patients with malignant pain or in the palliative medicine setting. And in fact, I would say that patients in our patient population are even at enhanced risk for opioid-induced respiratory depression or unintentional overdose. So we have begun integrating using the Reassured tool in screening all of our patients in the palliative medicine clinic for the need for co-prescribing naloxone. And in fact, any patient that screens out in the risk category of 4 to 7 goes home with a prescription for naloxone and has education of their caregivers in the clinic prior to leaving with their prescription for the opioid and naloxone. It's interesting that this recent report in JAMA also showed that in a retrospective study done in a very large Medicare patient population in Tennessee, that the initiation of a long-acting opioid was associated with a 60% increased risk for all-cause mortality and a 4-fold increase risk in the first 30 days of the initiation of a long-acting opioid. So I think that the risk of unintentional overdose is much, much greater than what we probably have been thinking about in the last several years. Certainly, these patients need to be counseled about safe storage and disposal. A very interesting study, again, done at MD Anderson, showed that 19% of their patients stored their drugs out in plain sight. 69% of them kept the opioid hidden but unlocked, and only 9% of those locked their opioids. And the 9 that locked their opioids were people that had a very high history of misuse and abuse in their past. So they wanted to make sure their drugs didn't get stolen. 75% of patients were unaware of how to dispose of their opioids, and in fact had their opioids still at home. So Maria's asking, I would like to think both the patient, if cognitively able, and the caregiver should be trained. Home alone would be more difficult. How would the patient give it if they are obtunded? We want to make sure that the caregivers are always present when we're co-prescribing naloxone. Absolutely. Chris says, we are struggling with what to do with our older patients on higher doses of opioid in the palliative care setting and naloxone that live alone. I should have read that one first. Do you give it or not? If so, should there be a designee or to train on? We would always want to try and find a designee to train prior to giving the naloxone in these individuals that live alone. So let's see, where are we at here? I think we're just about done. So, there's lots of these options. Again, I think that we need to find ways of making relatively inexpensive options available to as many patients as possible. And I'll just stop by showing you, this was a final policy that we had put in place at UVA that we're trying to mimic here at the University of Iowa, where we do use universal risk stratification, that we educate the patient and the family on opioid safety using an opioid treatment agreement, and review that each and every time, that we use the PDMP every time we see the patient in every visit prior to any new opioid prescription. And the frequency of the urine drug screen, again, is based upon that risk stratification. And then tightening the leash as needed in those patients that continue to show rising levels of aberrant drug-taking behavior. So with that, I'm going to stop. We have about 5 minutes and try and entertain any questions. And I lost the chat. Where did it go? So if you want to unmute your microphones, I can't seem to locate the chat feature all of a sudden. Disappeared. Oh, there it is. Okay. We lost your slides. When did the slides blank out?
Just now.
Oh, sorry. All right. Any questions or comments?
So James, in the hospice population, should we be as worried about concurrent opioid and benzodiazepine use since it's so commonplace? Or is that pretty much just limited to chronic non-malignant pain? But then the palliative care side becomes a grayer area.
Well, Chris, I think we've been having active discussions about this for the last several months. The surveys that have been done in the hospice literature about the reasons that benzodiazepines are used, they get used for a lot of different reasons, particularly in patients who have dyspnea present. But the evidence base for using benzodiazepines in dyspnea is very, very poor. I think that for the most part, we should be going away from using benzodiazepines in patients in the palliative care setting and in the hospice setting as much as possible. I think it's really a dangerous proposition in patients that become increasingly more frail, have advancing illness. I think that we can push them over the edge very easily with those benzodiazepines being present. So I think we need to really go back and thoroughly reassess, why do patients need these benzodiazepines to begin with? It's obviously a difficult situation. If they come to us, they've been on chronic benzodiazepines for 10 years. But I think for the most part, I want to try and limit benzodiazepines as much as possible in the majority of our patients. And Cashel just did a quick scan of the patients that were coming to clinic this week, most of them from the oncology clinic. 65% of them had a benzodiazepine that had already been ordered and was on board. These were people, most of these people were newly diagnosed. So the oncologists are just making it a habit of, oh, well, I'm just going to give you a benzodiazepine just in case you need it. We need to get away from doing that.
Well, I think that's commonplace in the hospice world as well.
Yeah, absolutely. And, the data, again, shows that for the most part, there's really not a lot of good reason to do it. So sorry to go off on the rant there.
No, that's why we're lucky to have you here today. Are there any other questions for Dr. Ray? I know we're getting close to time. Anybody else, either live or via chat?
This is Michelle. I don't have a question, but I can definitely speak to a patient that we had that we followed all those risk mitigation strategies. It was a head and neck cancer patient who had no active disease, pain that was chronic and not necessarily based off of his cancer, and ended up with a son at home who was abusing dad's meds, and we went all the way to Suboxone and couldn't even appropriately dose that, even though we were only giving like a week's supply at a time. So it's definitely a challenge that we see. So I was glad that you presented on this topic.
Thanks, Michelle. We have a young woman right now who has widely metastatic gynecologic cancer and was being seen by our medical oncologist, who had unfortunately decided to use hydromorphone on a routine basis to control her pain. And then after doing some dose escalations, sort of punted the patient to us to help with the opioid use. Well, when we did a PMP review, we found out she was seeing other providers. We did a urine drug screen and found out that she was actively using methamphetamine. And she continues to use methamphetamine as her chemical coping as her disease progresses. We at this point have told her that we can no longer manage her opioids. We're happy to continue to see her, but we will no longer be writing her opioids. And we had to do that with several patients that I interacted with at UVA as well, who continued to test positive for cocaine. I think it just puts the provider, the institution, the community at too high a risk for those things to continue to happen.
Mm-hmm. Mm-hmm. Yeah, we had recommended DCF on several occasions because this son definitely needed substance abuse treatment. And we started with fentanyl, we went to methadone, then we went to Suboxone eventually, and the father wasn't willing to do anything, so our hands were somewhat tied. And when I left residency, that was the status, that there could be no more Suboxone even. It was a really sad outcome.
Yeah. Yeah, you hate to do that, and a person that you know has a legitimate medical need, they've got widely metastatic cancer. Those are the ones that are the most heartbreaking, but at the same time, we have to protect ourselves and everybody else. And it comes down to having just the conversation, look, it's your drugs or it's our drugs.
Right, yeah. So thanks so much for this talk. It was really great.
Thanks, Michelle.
Okay, anybody else? Well, Dr. Ray, I can't thank you enough for giving us this presentation. Unfortunately, I had to be in and out, but I look forward to listening to the recording. The recording will be available on the Society of Palliative Care Pharmacist website under the members portal. I believe we're going to take next week off to enjoy Turkey Day, and then we'll be back the week after Thanksgiving, and I'll send the topic out then. Thanks everyone for tuning in, and once again, thank you, Dr. Ray, for all your insights and expertise.
Thanks, Chris.